now we started with the live case, and I'm a chairman Dr. Muramatsu, Toshio Muramatsu from Japan, and the other three panelists, Dr. Lee and Dr. Han Chen and Dr. Y.H.M. So now we started the case, and please, case summary, please.
Patient is a 71-year-old male patient who was referred for the treatment of LAD CTO lesion. He had a symptom starting at 5 months ago and had the initial procedure at September this year at another hospital. He has diabetes, hypertension, and taking medicine for the hyperlipidemia. He's an ex-smoker. His chest PA and ECG is unremarkable, and echocardiography showed no regional wall motion abnormality, which means that the territory of CTO is myocardium is still viable. So we already had we already took a angiogram for the current status. And this is the angiogram of right coronary artery. You can see there's a diffuse mild to moderate stenosis at the RCA. And you can see a septal collateral going up through to the LAD. We already took the FFR for this RCA, and it was 0.9. Now, so this is an areocranial view, and you can see that the LAD is quite large. It's not diffusely stenosed or calcified or shrinked, which is good for stenting, I think. And we can see several candidates of septal collaterals that we can use for the intervention, but mostly it is located at the proximal portion, which is connected to the distal cap of the CTO. I think we have to discuss for what kind of collateral we can use for the intervention. And this is a caudal view. I don't think that this view is quite good enough to assess the connection to the PDA. But maybe we can have some search for a collateral that is connected to more distal part of LAD during the procedure. So this is the caudal view of the left coronary artery system, and you can see there's a stump at the proximal portion of LAD distal to the first diagonal. And in this view, it seems that the morphology of the cap is a little bit tapered. You can see some tip at the currently mid portion of the cap. There are some calcification at the proximal portion and at the mid portion of the CTO lesion itself. And we can also delineate the distal portion in this left coronary artery angiogram. Now, this is areocranial view, and so just looking at the left angiogram, it's not quite sure for to assess the morphology of the distal cap in this view. But according to the right coronary angiogram, the distal cap is located just at the big septal, so we assume that there is a bifurcation at the distal cap, which is not a good signal for reentry. And this is another view of RCA cranial view, and you can see that the morphology of the proximal cap of in this view is a little bit weird. Maybe there's it's a taper tip, but there is some bump at the mid portion in this view. We have to find out what it is. Okay, and this is spider view. As you can see, we can also see a slightly tapered tip in this view. So because we assume that the vessel size is quite large enough, and maybe just looking at this angiogram, we can access to the CTO targeting the mid portion of the proximal cap, and that will be the exact location when you select the anterograde approach first for this lesion.
Okay, this is the baseline angio of this case, and actually, this was a failed case from another hospital 1 month ago, before I did the case, and you can see it's a relatively straightforward, has a straightforward anatomy with several septals and tapered anterograde tip cap, and maybe the JCTO score would be about 2 because it's a failed case, and we see some calcification within the CTO, but it's straight, relatively short, and we have several interventional collaterals for candidates of retrograde approach. So I think we have both options. We have anterograde approach option because it's a tapered tip, relatively large vessel maybe, and we also have some retrograde option. So any comments for this baseline angio?
Hi, Dolly. So this is Yuho.
Yeah.
Can you? Yes. So I think this is tapered. Actually, the proximal cap is tapered. So therefore, we can consider to start with the anterior approach. Of course, we need to put the catheter to make a contralateral contrast injections because the CTO ended before the bifurcations, and this is reattempted cases. So therefore, the antegrade wire may go into the subintimal space easily, which was created by the previous interventions. So if the wires go into intimal space and also the CTO lesion ended before the bifurcations, so there may be chance of the losing the major diagonal branch. So therefore, if you go to the subintimal space, I would suggest we can go to the retrograde approach earlier. So this is the very brief preliminary idea. Maybe we can discuss a bit, so therefore we can have a better plan.
Yeah, right. Actually, contralateral injection in this case is mandatory because we know that there is a bifurcation at the distal cap, and in this kind of case, we have to clearly delineate the distal cap to even if we do the antegrade approach. Of course, even if it's not for this case, the contralateral injection is mandatory. Dr. Muramatsu, how about you? Is it a very easy case for you?
No, I don't think so. But I think the anatomy of the proximal cap is looks like something like a thrombogenic occlusion. My impression in the proximal cap. So just like the stump, but something like thrombus containing a stump region looks like. And so even for the antegrade approach, we can see the distal vessel image. So that reason why maybe something like a small channel connected to the distal.
Yes.
So that is we have a chance to the antegrade approach, of course, at first. And on the other hand, the retrograde approach, the septal channel, some septal channel connected to the LAD distal, but it's not clearly from this image. I don't know the details, but do you see that something like appropriate the retrograde collateral channel? You can see that.
Okay, I think you mentioned very important point in this case. So you told us that the thrombus is suspicious because of the cap morphology, right? Yeah. So
Yes.
I think we will see the other hospitals angio, but I think the previous operator did this procedure and deemed it not a CTO, and that was the failure. The reason of the failure of the previous one. So we can learn some learning points in this point. And in our hospital's baseline angio, the intervention connected to the distal LAD is not clearly delineated, but actually there was a good candidate for the retrograde approach connected to the distal LAD when we see the previous baseline angio from other hospital, and we can see it a little bit later. Okay, we will go on.
So this is a cross-sectional view of this CTO, and you can see there's calcium at the proximal portion. There's some calcium at the mid portion of the CTO, and the most important part is that if you look carefully, the proximal cap is a little bit tapered, I think, and the vessel is quite straight. And also the vessel itself is quite large enough. Now we can go to the LV short axis view. Now adjusting the house field unit, you can see that this is the LAD, and the lumen which is filled with the blood is just at the mid portion of the totally occluded segment. That means that it is wise to access just the mid portion of the proximal cap to access the CTO lesion itself. The good part is that I don't see dense calcium at the entry portion, and the calcification at the CTO segment itself is actually a superficial calcium, and the mid portion of the CTO segment has some soft tissue, which is a good signal for wiring. Now the bad portion is that there is a bifurcation at the distal cap, which is a big septal, and we have already observed this morphology through the angiogram. Now this is a long axis view, which is quite similar to the areocranial view of the angiogram. And if you look carefully, now there is some tapered portion at the proximal cap here, and we can target through the calcium at the upper portion and the lower portion. If it's visible at the angiogram, we can target the wire going through these two dense calcification, and then go through the distal cap. Now, you can see that the vessel size is through the CT is almost 4 millimeter, so that is quite a large vessel, and the roots of the wire should be very straight. In this view, the vessel does not have any angulation at the mid CTO segment itself. So the course is straight, which is quite good. And the total length would be around 15 millimeters. And looking carefully, maybe there is some contrast filling portion at the mid portion of the CTO segment, which indicates an island. I'm not sure at this CT, but it is suspicious. Now this is a similar view of the spider view, and similarly, the proximal cap goes just at the mid portion of the CTO segment. So even in the spider view, it is wise to target the proximal mid portion of the proximal cap. Okay, we had some information regarding the CTO segment itself through the CT, and I think it is worth to discuss about the strategy regarding this information.
So first of all, I would like to know what kind of in what kind of situation you take a CT. So CT provides a very good information for complex CTOs, but in my practice, I have changed my strategy to take a CT more frequently these days, because even in non-complex CTOs, I thought that it is very useful for taking CTs and have some information, especially for the CTO segment itself, which cannot be seen in NGOs. And we all know that there is recently a CT, the RC randomized control trial that compared the strategy of taking a CT and not taking a CT, and the total successful rates was significantly higher in the CT group. So, Dr. Alan Chang, in your practice, do you take CT in all your cases, or you selectively do the CT?
Yes, I think the practice very much throughout the Asia Pacific region. I think it's well known in Korea, CT, particularly for CTO intervention, is quite a usual approach. But I think in Hong Kong, I don't know whether Dr. Yu-Ho had the same feeling. So for us, we seldom had the chance to access to CT angiogram, particularly for CTO intervention, unlike those structural heart case. I think our radiologists and most of our colleagues didn't really familiar with the CT software by ourselves. So I think it is always good to learn CT. Otherwise, just depending on the radiologist report the CT finding, they may not really know what to report, but just report there is a occlusion. Yeah, I think we really need to sit down by ourselves to go to read the CT by ourselves, just like what you did just now. I think in clinical practice, I think particularly for a failed case is, of course, will give you a great information about the failure. Particularly, I think in this case, also will give you variable information. But for us, we seldom have the CT angiogram.
What's the situation in Japan? Is CT frequently took in CTO cases, Dr. Muramatsu?
Yes, in Japan, CT is very popular. Most of the cases were done in the outpatient clinic at the cardiac CT. So most of the cases was done in cardiac CT before angiography. Yes, but quite common.
So personally, I used CT in selected cases, such as osteo CTOs, osteo LAD or circum CTOs, where we have to locate the initial parts of the antegrade wire, or a very long CTO where the root is not quite clear whether it's straight or not. And also, as you mentioned, Dr. Chan, in failed case, I always took the CT. But these days, if the patient do not have a chronic kidney disease and it's not a contraindication, I frequently use CT. What's your situation, Dr. Jong-Young Lee? We live in the same country.
Yeah, also in Korea, it depends on the individual hospital or physician. In my hospital, also not easy to undergo the pre-CTO PCI CT angiography. In that situation, I must use my brain fully. But if possible, also I use the CT angiogram before CTO PCI. As you mentioned by Pyong Lee, recent randomized trial showed the CT angiogram guided CTO PCI showed the higher success rate, I believe. But sometimes it is not feasible, as mentioned by Dr. Chen in Hong Kong. So I think the very selected case, CT angiography is really helpful, but some portion of the CTO PCI, I think it does not necessitate the CT angiography also. So it is not difficult. It is not easy to differentiate which situation is necessary, is not necessary. That's my big concern.
Yeah, I think it depends on the experience. So in this particular case, which I had a very valuable information for me, it was that the assessment of the proximal cap. For if you remember the RAO cranial view, the morphology of the cap was a little bit weird, right? We have a tapered tip and there was a bump there, but in this CT, actually the tapered portion was exactly at the mid portion of the CTO segment. So I thought that, well, this is the point that I should wire, not the bump itself, right? So that was a valuable information for me. And another point is that it's a relatively straight portion. So that was quite some information from this particular case. So I told you that this case was a failed case, and in failed case, it is always important to review another hospital's angio. And that's a very important point because we should not repeat the failure mode after assessment of the other hospital's angio. So let's look at the previous angio and discuss further.
So if we face a case that has been failed by another session, it is always important to review the failed case if it's available, to not make a mistake and have a successful one in this session. So we got the angiogram of the previous session from another hospital, and you can see that this is a diagnostic angiogram, the JR. So this is a counter view, and you can see that we can see some available septal collaterals can be used for the intervention, and it was not accurately shown in our angio, but according to the other hospitals' angio, there are some potential septal to use. Especially, we can see that there is another good septal collateral, candidate collateral at the distal portion, which is connected to the more distal portion of the LAD. The angle of attack is not that favorable, but I think we can direct the wire to the proximal portion if we just success to connect this cross this collateral with the wire. Okay, this is a counter view of another hospital, and you can see that the morphology is a little bit different with our angiogram because our angiogram was took after the failed procedure. You can see that the stump was quite blunt at that time. And this is a cranial view. It's not definite. It's overlapped. And I was very surprised to see this this picture because they did not took a thorough angiogram for the entire left coronary system and just started the wire. So you can see that the initial wire was done without any microcatheter support, and the operator is rotating the wire, and the wire seems it is a workhorse wire. So I think they just misjudged this lesion as regarding not a CTO lesion maybe, or just simply thinking that the wire will cross easily. But that's always a mistake when you deal with a CTO. So after the next picture, we can see a small micro catheter at the proximal. They took a micro catheter in this portion, but still they are using a workhorse wire, I think. And the wire somehow passed through the proximal cap right here. And there is a contrast filling lumen at the mid portion of the CTO, which I think we saw at the CT in our hospital. but we are not sure whether this wire is in the intraluminar position in this view. But we have to always be aware with being the wire at the extra plug space, because the initial portion of the wire is just located at the greater curvature portion. So there is two possibility. So according to our assessment in our angiogram and CT, the wire should be just at the mid portion of the CTO proximal cap, which is the ideal portion. But this wire at the previous session went through the upper portion, which is greater curvature. So there is always a possibility of going through the extra plug or the subintimal portion in this kind of morphology. So somehow you can see that the wire did not go through the intraluminar space at the distal, so they use a parallel wire technique. And I think this is a tapered tip wire. And they are trying to wire it using a drilling technique, but the wire is somewhere else at the LAD. So in this position, we do not definitely see the distal LAD lesion, which was quite visible at our session. So that means that somehow there could be a vessel injury, or the wire has been in the subintimal space that precluded to delineate the distal portion by the left angiogram. So they next, what they did, they inserted the right coronary artery system guiding catheter and started to take a retrograde angiogram, contralateral injection of the dye. So this is typical example of a failure course of a CTO session. So I think the CTO session should not be regarded as easy, and we always have to prepare very thoroughly for every CTO session which is even regarded as easy one. So you can see that through the right angiogram, the wire of the left is located elsewhere. I don't know where it is, but it's somewhere else. And you can see it's failed to go through the true lumen. And this was the failure course of this previous session. So I think it's worth to discuss how to, why they failed, and how to do my strategy to not make mistake of their failure course.
Okay, this was a previous NGO, and I think we have lots of things to say, especially for our fellows and the CTO PCI beginners. So, Master Dr. Barma Sensei, do you have any comments?
Yes. At the first, it is not enough to preparation. So it should be necessary to at least the retrograde contralateral injection and both approach and try to analysis of the anatomy of the CTO region is the first of all most important issue. And so after that, to try to discuss or something like evaluation of the regions and how to do it, what kind of guiding catheter and what kind of guide wire, what kind of micro catheter we can use that. So after that, trying to the antegrade or the retrograde. So based on the complete, the precise anatomy of the CTO regions are necessary. So it should be necessary to the bilateral injection and the contralateral injection, and trying to ranks of the CTO and where it's the proximal cap anatomy and distal cap, and so the preparation is not enough for this kind of the fast CTO cases, I think.
So based on this information, I mean, the failure mode of another hospital, the CT, and our baseline angio, what kind of strategy do you want to select? Integrate first again, or a retrograde approach? Because we now know that there is a candidate for the retrograde, not a bad one. So would you just do a primary retrograde, or you deal with another integrate session? How about your opinion? Maybe Dr. Yo Chen?
So in this case, first of all, I will put a true catheter to prepare, as mentioned by Dr. Pisu. So we need to make a contralaterals and also integrate congestions at the same time. So therefore, we can have a more information about the CTO lesions. So in this case, I will still, for the second attempt case, I will still go for the integrate approach first. And I will make a selective contrast injections through the microcatheter in the proximal part of the LAD. After making a contrast injection through the microcatheter, so basically we may able to see maybe some kind of the small channels. If we could see a small kind of channels, we may consider using the maybe soft wire through the HTR wire, guided by the contralateral contrast injections, whether we can use this wire to pass through the CTO lesions. If not, we may need to consider to use the STA or some controllable wire, for example, the Gaia next wires, to see whether we can manage the CTO lesions. Of course, we need to guide it by the contralateral contrast injection. In this case, the CT is very important because this is the CTO lesion ended before the bifurcations. The distributions of the calcified plug is very important for us to know. If the calcified plug is located at the outer curve, then the wire should be aimed at the maybe start towards the inner curve, and then to go along the inner curve, go along the septal size, whether we can avoid making another subintimal space. So therefore, the CT scan is very important. So therefore, we can know the distribution of the calcified plugs. We can avoid hitting on the calcified plug as well. So therefore, this is the information that we need to gather before doing the CTO lesions.
Yes, I think you mentioned a very important point, because if now we have the information of CT and our NGO, and looking at the previous NGO, I thought that the main reason they failed was that they did not prepare thoroughly, as Muramasu mentioned. And also, I think they failed to insert the wire at the appropriate point. They just did use the workhorse wire without any microcatheter support. They did not, try to locate the exact point of the entry. And after an inappropriate position of the wire, it's very hard to overcome the whole process. So what I thought is that I would like to select an anterograde first approach. Of course, I enjoy to use a retrograde approach, especially in the failed case. But I thought that this case was worth a try for an anterograde approach with our CT information. Just point it at the appropriate position, and then the proximal cap, and just locate it. We have angio dense calcium, and we can guide the wire within the calcium, as Dr. Chen mentioned. Now, another thing I would like to focus is that they use the parallel wire technique. And of course, we may not have any information during the detailed information during that previous session, but I thought that the method of the parallel wire technique was incorrect in this session. I mean, they did not. I think they did not use a appropriate view for the parallel technique. They did not use we may not have the exact angio, but for the parallel technique, it is wise to use the second wire with a view with in the maximal separated position for the angio and the first wire. But somehow they did not use that view. And the second one is they drilled it with a polymer coated tapered wire. But for the using a second wire for the parallel wire technique, it is wise to use a more controllable wire to access the point that you want to do it. So all the methods for the beginning and using some CTO techniques was wrong, but I'm not sure. So my strategy was to go to the integrate first procedure and do it the same way as they did again, but with lots of information and some thoughtful methods. So we would like to go on and look at what I did.
Caudal view, and you can also see a favorable morphology of the proximal cap. I always think it is very important to get confidence of the wire location of the proximal cap in any session you use an integrate approach. That the exact position of the correct position of the wire at the starting point makes your session more easy, and this is always important, I think. So I think it is worth to discuss about the wire and the microcatheter selection in this case.
So I don't think there is a very straightforward answer for any microcatheter or wire selection, but do you have any preferred microcatheter or initial wire selection in this case? Could you discuss?
Considering that there is no dense calcium at the CTO.
If I am a physician in this session, I think that also in the case of the integrated approach, I think that we must also use the parallel technique. So in this situation, I prefer the two-lumen catheter such as the Sasuke with the wire XDR mentioned by the Dr. Chen already. So
do you mean that using the Sasuke at the beginning?
I would rather use
maybe, yeah.
Microcatheter that has a relatively
because there's a possibility to use a parallel technique somehow.
Yeah,
right?
yeah.
I see.
Yeah.
How about you, Dr. Muramatsu? We want to learn lots from you.
Now the first wire I want to use is
I use first of all the simply
controllable wire.
usually use the Corsair Pro.
So
but of course, if I do the parallel wire techniques, I usually use double wire two-channel two-way catheter, for example, the Crusade or Sasuke.
So my selection was actually a fine cross because you know I thought that the Corsair any microcatheter can be used in this session, but Corsair has a relatively stiffer tip, and the proximal portion of the LAD has some angulation, and if I use Corsair, it might lead my wire to a more greater coverage of course. I thought that according to the CTO, there's no calcium at the entry point, and just having a little bit of backup and having a controllable wire could be appropriate. So I selected fine cross and first the Gaia second wire. But I know that some operator would like to start with a polymer coated wire, and that could work. Yeah. So you see that this wire is at the tapered portion at the areocranial view, and I wired this point according to our CT finding.
Okay.
Dr. Pyramid, this wire is
Gaia
second. Gaia second.
It has to go right at the 1 o'clock direction.
I don't know whether the first angel had some hints. Apparently, there's some visible microchannel from the very first baseline angiogram, because you can see a little bit blood streaming down to the mid and distal area, although the flow is very minimal, probably because of the very competitive flow from the retrograde.
Yeah.
So from the angiogram, this time you can still see the blood streaming down, but of course it has been disturbed by the previous wiring. We never know whether the previous wiring is go somewhere, should be some animal somewhere, so it can't be likely to go to somewhere else. Maybe I may choose the polymer jacket wire first, probably, because you may go to the previous subintimal space, but now this time you have the beautiful retrograde visualization, and then in case it didn't really go to the target, and then it's offset to the, you can always use a parallel wire to redirect your second more directional wire towards the distal target. And I agree, I will use just a regular microcapitals, but more commonly, I agree with Dr. Maruso. We use talkable mic just to give you extra support and talkable force in case you want to drill inside the cerebral body.
Yeah.
And then it changed to a dual lumen capitals in case.
Quite soft.
Yeah, I agree that
And you can see
some
that
the polymer jacket wire in the initial trial would work based on the angio. There may be a microchannel there, but I selected this wire because you mentioned that the previous session has some wire in other space, and we never know. So I just wanted to control my wire in the exact position that I wanted.
Quite good in this position. I like it. Now I would like to advance.
Dr. Pyramid, how about your feel during the wire advance?
Fine cross a little bit
Well,
more.
actually, I had some resistance in some point, and I will tell you where the resistance was. I think it was in this point.
And then I don't want to just drill it, but I want
exact site of the CT segment, CT calcified
The
segment.
the most resistant part was at the
the wire is a
distal
little bit
cap
down
point.
course, right?
Yeah, and I think that was the point where the wire went outside, maybe, or the initial
It is
portion
worth
in
to
another
go
hospital.
just
But
at the mid portion of the two calcium.
so you can see that there is two calcium there, and
I think it's good.
that's a superficial calcium, so my wire should go in the mid portion of that calcium.
Now I feel some resistance at this portion. Okay, there's some resistance here, but the position is not that bad, I think. Okay, it's good. It's more advancing right here. Now,
I think the another discussion is when you come close really to the distal
I would
cap.
like to
So
take, right angiogram.
how do you decide to use parallel wire versus the retrograde option? Because you want to preserve the bifurcated septal branch.
Yeah, in my personal experience, the most important thing is whether you have an appropriate view for a parallel wire technique.
And,
I think it is never to go with the parallel wire technique if you have not an appropriate view,
like this.
widely separates
Okay. Then I think
the vessel and the first wire. If you are very confident with the wire position of first wire position, then you can use the second wire for a parallel wire technique. Unless then, it is better to use a retrograde approach.
In this position. So
I think for this case, either way will go. So how pretty sure to preserve the septal branch, because you have the distal target is really big. So even parallel wire, you have a reasonable chance of success.
Right.
Whereas for retrograde, you can probably be sure to preserve the septal branch. We can do the reverse cut in the
wire position was not bad, but at the
both options are okay.
Goes to
so I think the thing is that whether whether one approach could be more efficient than another approach, and whether one approach is more safer than another approach. We all know that using retrograde is a little bit more complication, and it takes a little bit more time. So if I have both options in this situation, in this time point, maybe I would like to use a parallel technique.
AP view or a little bit 에래요.
After all, I think it's always dependent on the operator's experience. For example, using various strategy, right? Some operators are very
In this
experienced
position, we
using
cannot,
retrograde and versus those using the pedal wire techniques. And another important point is how is the renal function of the page, because for pedal wire, you may need to use a little bit more contrast as well as compared to the retrograde,
Yes.
for my point of view.
Back good point.
Okay. Position.
Okay, you saw that
right
the wire was relatively straight in another view,
So
but
maybe
in
I
this
would
counter view,
like
the wire
to
was
relocate
far apart
my
with
guiding a
the
little bit.
distal LAD. So I took a chance to relocate my wire in this position.
Advance the microcatheter a little bit far more. Like this. Okay.
For the integrated approach, actually, we need to pay attention carefully where the wire deflects out. Wires and change from the positions from the very stiff positions. I mean that if we feel wires just different, then maybe that's the wires go from the intra to the subinterface at that point. So that we have to remember the position. And also wire deflect, and then we can pull back the wire possible to that size and redirect accordingly.
Theoretically, if there is a big bifurcation in distal cap, as you mentioned with the Alan Chen, lateral approach may be high chance of the preservation of the big side branches. So, especially in the Gaia second wire, easily can go to the some deviated space. That means which means the jail is high risk of the jail of the bifurcation. So
yes, right. So if you use the integrated approach,
like
the distal cap is also always a concern if there's a
force of the
bifurcation.
wire.
And using the retrograde approach, it always concern the integrated cap if there is a bifurcation. And we always have to try to locate the wire in the mid portion, not in the eccentric portion,
I would like to take a
not to lose the branch.
much better than previous one. Wow.
The wire position is not bad. Okay. Well, I personally don't feel any resistance in. Okay, but I told you that we have to always be careful. We have to identify the wire position in every view. Okay, I think it's not bad in the areocranial. The wire position is good. So I think it's worth to identify the wire position at the areocranial. 약간 벗겨놨죠. 예. So the wire position is better from the previous one, but it's still is in the extra plaque position, definitely. So what kind of strategy would you like to choose in this? So now I think it is a very good time point to change my strategy, because I already did this wiring about 10 minutes, you know. And you see that the position is not bad through the CTO, mid portion of CTO itself, but the wire goes consistently goes out portion at the distal cap. So this is a very frequent phenomenon when you deal with CTO that has a distal bifurcation at distal cap. And I think this view is very a good view to make my second wire position. So I would like to use a parallel wire technique in this time point. I'm inserting a 2.5 balloon to capture my microcatheter. Okay, 10. Okay.
So, yeah.
빼고.
may I ask how long time interval is adequate for retrial?
Maybe
The first trial was failed.
Reflection.
I think this case is just less than 2 months.
Consider that the
How about is it too short, or
large?
we need more time to try the second trial?
We definitely separate the first wire and the second wire in this position
Dr. Muramatsu?
at the reflection point. That is very
Yes, I think
okay, right?
usually about 1 month is enough. But recently, if you have appropriate reservoir channel, doesn't mind.
Please.
Doesn't mind. So usually, I try to 1 week later fail to integrate approach and try to retrograde. One week later is possible.
Maybe
I think it depends on what kind of complication you made in the first session. If there's a wide hematoma and lots of complication, then it's worth to, it's wise to wait about 2 or 3 months.
To where we want, according to the
location. So I choose the Parawai technique in this time point, but
that is why I chose
what kind of wire would you like to select in this kind of case? I actually selected the Gaia third, but would you prefer another wire?
You see,
Dr. Muramatsu?
in the scene, the wire.
Yes, Gaia third, or I prefer to use a Conquest Pro because of in this case this is areocranial. Areoportal is a very areocranial, very good view of the target of the true lumen, because they're just like 1 millimeter below as first wire. It is very clearly we can see the target. So the problem wire techniques, the key issue is how to find it, the appropriate image. Where is the second target? That you can do it. So it is very
now the wire is
very good
in position.
Wire technique.
So
at this point, I would like
thinking about the previous session. Now I did this session right now, but I think that the most appropriate view was this view for a Parawai technique. They used the areocranial view for the Parawai technique, but it was not appropriate in my thoughts.
Yeah, I think for parallel wire techniques, it's always need to use 2 orthogonal wheels to make sure, and from the wheel you're showing, actually the wire should go below from this wheel, and then it's always good to check another wheel, either the caudal or the left aorocranial, to see how the vessel goes left to right. So you need to go either up and down and left to right, and then with all this information, you can use the more directional wire of high penetration force to focus your target point, and then you will succeed.
Upper position.
Good point.
So so this wire is in a absolutely different position. I would like to check the right angiogram this position. Go.
Yeah, 1 millimeter below.
Maybe, right? Maybe. How about that? Because
you need another wheel.
Connection there. The second wire should go to contact the inferior wall of the distal portion, and it is not that bad. But I still want to identify the exact position in another view.
Because this is a Gaia third, so
in this case, maybe the caudal is not helpful because the wire is overlapped. Okay. So this is an areocranial view. Okay. Is it okay?
Yeah. Okay.
Okay.
Wonderful.
So
very nice.
The wire is in good position, right?
How about the reentry point? I think the reentry point is a little bit eccentric to the septal. Is it okay for you?
I think this is a typical example of the.
You have a back, actually you have a back exit from the distal cap. It's very close to the septal, but I think it's still inside the true lumen.
Yeah. So I think it's better to if it's really hard to locate exactly at the mid portion of the distal cap, but it's better to deviate the wire towards the branch. It's less probably to lose the branch. If the wire is eccentric at the opposite side of the branch, there's a plug there, and the plug could deviate, and after ballooning, the branch could be lost.
I think that you are showing very typical how pattern-wise technique must be done. Because in the first session, another hospital physician, they didn't use the pattern-wise technique. They did use just 2-wire, not typical pattern-wise technique. So this is a very typical situation of the pattern-wise technique.
If you are
so if the lesion was so soft that the Sasuke wire, Sasuke microcatheter passed without any resistance.
It is in the right.
So actually, in this case, the maneuver, how the actually in the first attempt, the maneuver of the first operator also tell us that the wire should go into the subintimal space located at the outer curve. So therefore, in this better to towards the septal
time point.
Usually, when we make space, the first wire is outer curve. So therefore, the second time, it is better to M in plus over the septal side in this case. So therefore, actually, Dr. Lee illustrated a very, very good example in this situation.
Prognosis of the patient is always dependent on the result of the stenting. So still we have to focus on the stent optimization and having a good result at the final according to the IVUS preferably. So that is more important.
So do you always use IVUS for stent optimization in CTO cases?
Please give me
because personally I always use IVUS in every CTO PCI cases. I think it's very important to optimize it, more important than non-CTO cases. We are dealing with calcification, lots of plaques, and diffuse disease sometimes in complex CTOs. And we all know that the stent optimization is important for the prognosis. And if I would like to choose, have an option for IVUS in various kinds of anatomy, I would like to choose using IVUS in CTO cases. Do you always use CTO in Hong Kong? How about in a Hong Kong situation, Dr. Chan, Alan Chan?
Yes, yeah, I think in most of our Hong Kong CTO operators, we're almost close to 100% of using IVUS. So I think for simple case, you get extra value, and even for very important for complex case, for example, you're doing a lot of, for example, subminimal working in the subminimal space. So at the end of the day, if you can successfully wire across the CTO, it is always impossible to do any integrate inject of a lot of injection to show where exactly you are going to land the stent. So at the IVUS, we always use IVUS to, apart from optimization, and precisely to locate our stent to make sure we do not miss the lesions and avoid further complications like the angiogram induced dissections, etc. And we use a lot of IVUS during the procedure as well, like the CTO IVUS guided proximal puncture, and then after it failed, and then we may use IVUS guided rewiring inside the CTO body. And even for retrograde, in case the retrograde wire goes somewhere else, we can use IVUS to check where exactly the retrograde guide wire is, and then you can work from there if we'll work further strategy.
And
so using IVUS is important when you deal with the bifurcation cap. So I always check the IVUS to find out the wire position. If the wire position is somehow too eccentric in the bifurcation point, or there is a flap there's a high possibility to lose the branch. So we need another strategy before stenting. That's very important. In every case with dealing with the bifurcated CTO cap, I think IVUS is needed. And I have another comment for the regarding the prognosis of
Maybe we
CTO
are
PCI
approaching
because
to
we
the
have
distal
limited
landing
data
zone around here, maybe. Okay.
on the definition as what is the
And
optimization
there's a subtract branch here.
in the field of
Relative-
CTO PCI. So we
superficial
have
calcium.
information
Now
that
distal
the
cap
most
is
important
coming-
factor
I think
is
this
the
big septa.
minimum stent
This
area
is a,
after the
CTO
stenting
segment.
in every PCI cases.
Okay.
And we have recently worked on this subject, and we found
Okay.
out that
There's lots of
the
clock there.
optimal
1, 2, 3, 4.
area
The vessel size is more than
post
4.0.
PCI for
Relative
the
small lumen
endpoint,
at
which
the
is a composite
proximal.
endpoint,
Now it's getting
cardiac death,
bigger.
MI, and
Maybe this is the
target
proximal.
revascularization
the stent
was
should be at
4.9
the osteal
square
dilator,
millimeter,
right? Okay,
which is
stop.
quite similar to the
So the
non-CTO
should
papers.
be a little bit shorter.
And I would
think
like to
the
ask
distal
one
landing zone
last
is quite
question.
good. We do not have any
Actually, we
hematoma
have
or
not
dissection
direct
or other
evidence of using
complications. That's a good
antiplatelet
point.
agent after CTO
Now,
PCI.
this is a
So,
distal landing here.
according to the European guideline and several subgroup analysis
right?
of big
Okay.
RCTs, just
The length should be around
dealing with a
38,
CTO
maybe
lesion is
long stent should
regarded
be
as a
okay
complex
here. The
PCI,
distal lumen
and they
is
recommend
around 3.4.
more than 6 months of depth as a
So
2B
maybe
classification
3.5
recommendation.
millimeter of
But
stenting is
actually, they
appropriate.
bumped all those
Now,
factors,
this is the
lesions that
LAD
require
osteum.
3 more stents or
Okay, the
60
vessel
millimeter
size is
more
also
lesion length
around,
or bifurcation lesions,
maybe
2 stent
5.
techniques, and CTOs in just
4.6, okay.
one factor and analyze
So, because there's a little
final
bit of disease
endpoint.
there
But
with
do
superficial
you agree
calcium,
that
maybe it's
in
better
every
to,
CTO cases you use
have
depths
our
more than
stent a
6,
little
or
bit 1
do you
millimeter,
think
2 millimeter
we need
outside
prolong the depth in
bifurcation
only selected
to
cases?
fully
How
cover
about
the lesion.
Dr. Jong Young Lee?
Okay, I would like to take
Yes,
exact.
also it depends on the stent length and the stent diameter. If in the situation of the CTO, the stent length is short, I prefer the short duration of depth and after the
Okay, let's take a
single
shot.
antibody therapy lifelong. But
Okay.
more than 2 stent, like the more than 50 millimeter, I think the even in the stable situation, I prefer the 12 months of depth and then after switching to single antibody therapy. So
on the location of the proximal portion of the
it is not easy to answer the simple one answer to all CTO intervention about the depth, the duration.
여기서 한번 찍어볼게요. 살짝.
Yes. Without any direct evidence, I think it is reasonable to select the optimal depth duration according to the final PCI result in every case, CTO cases. So in this kind of case, for example, I used one stent, 38 millimeter, and the final I was finding was very, very optimal.
Now 16.
So maybe 6 months is enough in this kind of
18.
6 months.
Patient. Okay, 20 corresponds to 3.
I think for the DBT after CTO intervention, it really depends on what you have done. I think just like in this case, so basically purely you are going all the way intra-plug, two-lumen wiring, your big vessels, your single stent. Is basically you're just like doing a straightforward lesion, but just happen is a CTO. Versus case you have extremely long stent like 100 millimeters overlapping stent, you go subintimal, and then yes, lots of complications, and probably prolong at least up to a years of DPD would be more favorable.
Yes, I agree.
Okay, please give another intracoronary nitro.
So what size is stent now? Is it 4
it was
or
3.5?
Yeah.
Okay, let's go.
And I think this is the final one.
This is the edge of the stent. Okay, there's no malapposition. The stent is well expanded here. Okay, this is the CTO segment itself. There's a acoustic shadowing because of superficial calcium, but the relative expansion of stent is good. Maybe this portion, the vessel is a little bit big, but I think it's acceptable, right? Okay, now.
Wonderful position.
Very precise
Thank you.
hospital stenting.
Okay. The stent is 1 or 2 millimeter outside the ostium of the LAD, which I expected to be there to fully cover. Maybe it's perfectly located. Okay.
Yeah,
So
okay.
maybe the final shot. Okay. Let's take the zoom out and another final shot here.
Good.
Okay. Okay, so this would be the end of our case. Thank you for all. Thank you for our patient and our staffs, and we wish to meet you next year. Thank you very much.
Okay, so thank you for your attention. This case, very interesting case, very educational because of a typical Paraguay techniques. So they failed integrated approach. Then second session is successfully the typical Paraguay techniques. And especially for the important issue is how to find appropriate the image to analysis of the CTO region. And second point is the first way going to the fourth room, but how to find it appropriate direction. So the second way, where is the target of the children? In this case, is a cranial view, and the second wire is a 1 millimeter below as a first wire. This is a very important issue. So very successfully the Paraguay techniques. So the congratulations is a successful one. And thank you for your attendees of the nice operator, Dr. Rees, and panelist, Dr. Reed, and Chan, and YA Chan. Thank you very much for your cooperations.